Well, thank you for coming to our little workshop, and it really is a workshop. So if you can feel free to jump in and tell us about things, how things are at your shop. I'll tell you a little bit about us in Battle Creek. We're a group of 4 medical oncologists, and we have 2 nurse practitioners. And in all honesty, I have to say that much of what I'm going to be talking about, the data, I have can take no credit for, because I've only been there since the end of October, actually, 2016. But being a physician, I have no problem taking credit for things that I've had little or nothing to do. So Louise called this the Tim and Tim show because of Tim and Tim, TNT. So I do hope the presentation will be dynamite. So they have us listed as pain management for physicians, and that's not really what we're going to talk about, really. We're going to be talking about the MOQC measurements for pain, and that are going to be important now as we go forward for reimbursement. So we really should be calling this MOQC, no pain, no gain. So let's see if I can work Tim's. Oh, I could do this with this one. Okay. So takeaways, really, because we really care about hearing from you, and we want to make sure that you feel like you're being listened to, and because we want our Prescani scores to be really good. It's not just our objectives, but we're going to talk about the MOQC measures, the pain measures, talk a little bit. The other Tim will be talking about the Bronson Cancer Cares process, discuss rational interventions to improve outcomes, and share relevance and applicability to other clinics. So the why of pain management, you all know it's better medicine, and now it's going to be better reimbursement. As Dr. Burson said, we had that slide this morning that showed that if we take care of the symptoms, we can help improve overall survival, which is something to do. Let's see, where's my... Okay. These are the MOQC pain measures, pain assessed by second office visit, and 2 most recent visits, pain intensity. Whoa, okay, I'm just dangerous today. I was going to say that increasing evidence of better symptom control leads to better survival, and we saw that slide today. And our patients have pain. 59% of the patients undergoing active anti-cancer treatment have pain, and 63% of people with advanced disease or metastatic disease have pain. And the kind of interesting thing that I didn't really realize until I looked at this old study was that even the people that have been treated with curative intent, about 1/3 of them still have pain. Even after they finish all the stuff that we do to them, they have pain. And the people that do have pain, more than 1/3 of them rate the pain as moderate to severe. So we talked about the better medicine part, better reimbursement. As you've heard, if you've been to the regional meetings, that we've got the value-based reimbursement coming up, and pain is one of the key components of that. Pain addressed appropriately, these are the different core measures, along with smoking cessation and talking about tobacco, and then hospice and palliative care referrals and services. And then MIPS, Bruce Mackey, I guess, is doing one of the other workshops here along this. So did everybody go to one of, or somebody from your office go to one of the regional meetings? Okay. I think personally that we have the best name for a region, Lemoore, as opposed to, now WOW ain't bad, west of Woodward isn't bad, but I think compared to Lemoore, I mean, this really is good. And so this is the data that they showed us. And I really wish I could tell you that, so these are the different practices in our area, and I wish I could tell you that we were over here, but we were actually over here. But we do have a confidence interval that maybe we're up this high. But again, this is data, combining the fall 2014, spring and fall 2015, and spring 2016. So it is what it is. I can't really explain it very well because I wasn't there at the time, but we'll go forward and show you some other data. Then this is the end of life, pain addressed appropriately on either of the 2 visits before death. And here, we're doing a way better job 90 or almost 90% with a confidence interval pushing us up there, especially compared to the rest of our, we're kind of a little bit better than the rest of our group, and then better than MOQC, a little bit better than COPE. So we've got recently then our data from broken out from these individual recording periods. And so this is the spring 2014. How many people, does anybody still use a chart? Paper chart?
Yeah, I just found out actually too late after abstraction, because this was my first time doing COPE, and I didn't really have anyone before me showing me that we have a hybrid system, so we have some things on EMR and some on paper. So we scored very low for quantifying pain because I didn't know it was in the paper chart.
Okay.
So that will improve in the fall, but we do use outpatient clinic forms on paper form.
Okay. So is
I'll
there,
be pulling paper charts.
so is there somewhere?
Inpatient now, the VAS scoring is on the EMR.
Okay. Now, do the doctors have the computers in the exam room, or do they wheel it on a cart like a computer on wheels, a cow, or a workstation on wheels, or a WOW? Yeah, I personally, I use POT, paper on table. So that's just me, because I can't see that well. You know, when I'm looking at a laptop, I just can't see it that well. I need like a 40-inch screen. And the exam rooms are big, but they're not that big. They're just not that big. So I do a hybrid system. I scratch things down, and then I go back to my computer, and then try to click, and then I go back and forth like that. But anyway. All right, so we're talking about our results. So pain by second office visit. In our EMR, the pain is recorded by the MA, but in the EMR that I've been using, both in Petoskey and in Battle Creek, the pain is not up there like the fifth vital sign. It's way down there below. Let's say, do you feel safe? And did you use the gas card to go to Africa? Those kind of pertinent questions. It's down there somewhere. So what's happened to me a lot of times when we're talking about this pain intensity is that, maybe I'm just the only doctor, but sometimes weird things happen. Like I don't know, patients tell me one thing and they tell the nurses and the MAs something else. And I'll have a visit with a patient. I'll ask them how their pain is and how they're doing, and the patient will say to me, "Oh, I'm doing just well, doc. Thank you very much." And then I go to dictate because I didn't have the cow or the WOW to see it all. So I go back, and because the MA is putting it in the computer, all right. So then I go back to my office and I'm trying to dictate. And as I'm dictating, I'm doing vital signs, and I usually put the pain measurement up in the vital signs along with it, right along with it. So I'm scrolling down, are you fear of falling? Are you safe in your environment? All this other stuff. And I see a pain of 6. And I think, crap, she didn't tell me that. She didn't even mention it. So how can I address something if I don't see it? So because I use POT, I have then my MA along with the vital signs now put the pain level written down on the piece of paper so I see it when I'm face-to-face with the patient, so at least I can do a better job of addressing the pain. Because when you put a pain level of a 6, then, COPE, one of their measurements is, so what'd you do about it? And if you didn't see it, you don't know. So anyway, so we see our data. So this is pain by second office visit, and this is spring 2014. Spring 2015 and fall of 2016, and you can see the codes here. Pain assessed by second office visit, intensity by second office visit, and then the plan for moderate severe pain documented, and then pain addressed appropriately. So this means that you did everything right and you got a good score for that. So this is what we had in 2015. 2016, and this, of course, is after I came, so everything's 100%. This, I don't know what they were doing back then, but we can say at least here I am up here. So, again, I will take credit for things that I don't deserve. But so that's the pain by second office visit, and then pain at the two most recent visits here again, 2014. Again, for Battle Creek Cancer Center, there's a lot of turnover in terms of the providers at this time. It's hard to really know what to make of these numbers, because now we've got a kind of a core group that's consistent, and I think we're doing better. Actually, if you look at even like the Lemoore, like your regional data, and if you look at the variance in pain reporting and COPE scores compared to one of the articles that Dr. Blaney wrote for MOQC, I think it was in 2011, there was a wide variance in these COPE measurements, and we've at least now we're down here. We're within striking distance of each other. So there's been some improvement. Then we go from the pain of two most recent visits then to the end of life, and what I want you to see, all right, is the axis. 75%, 100. And you look over here, you think, oh, well, so what's this all about? Well, this is actually means 96%, so that ain't bad. And again, that again is what I talked about, the plan of care for moderate and severe pain documented on either of the last two visits. But I think it's a little bit easier at the end of life than when we saw early on the first two visits, and making sure that actually gets done. So 100%, 100%, 90, what was it, 96 or something percent, and a little bit better than that. So that access there. So doing better at the end of life care. So I'd like to now turn it over to the other Dr. Tim, who will tell you what they actually did and how they did it.
Well, when we were putting this together, oh, that's right, I have to wear this. I didn't know about being the anchor, because as you can see, Dr. Cox is hilarious.
He thinks he is.
No, you are. The patients love this guy. It's upside down. Hey, there you go. Okay. So, how did it all start? I started in early 2015, and when I keep saying myself, I mean the palliative care kind of movement at Bronson Battle Creek started then. I'd like to think I was a big part of it, but there was already a whole push at Bronson. And in fact, they started we started with palliative care, and then it went to advanced illness management. And that's a whole other discussion. But, so AIM. We're part of the AIM team. I'm sort of the redheaded stepchild. But the push was to look at a couple things: advanced care planning across the system and in our community. That's a big one, and in fact, we're doing that now. We're in the 90s now for advanced directive completion, I believe. So we're really beating that home. But anyway, so we started out looking at our pain scores, which you can see in 2014 were abysmal. And they said, this is one thing we got to work on. I said, oh my God, thank you. I love this topic. That's what I wrote my dissertation about. So
You like pain?
I like pain. I like to see patients in pain. Just to give you like the overview, because it's, when we were first developing this, it's, what do you say? I mean, there's so much to say about pain, but what we did personally and what we used, I guess that's the process I'd like to discuss. Basically, all of March for me was insane. I don't think I saw any patients. And we ended up plowing through this. Now, in 2015, we started doing palliative care referrals. We went from 5 palliative care referrals across disease diagnosis to 22 just for breast cancer. And I think it was 88 total. Now I'm not tracking the numbers because it's higher than that. And we have people that do that, which is nice. We're gaining speed, but in 2016 we said we've got to have a formal process, because we've got a palliative care program or an AIM program that doesn't solve some of the issues we're having. And patients felt disconnected. Again, take this pill. Well, did you set them on a bowel regimen? I mean, you're prescribing an opiate. I won't use the term narcotic. I'm not a police officer. You start them on an opiate, but you do anything to prevent constipation. So anyways, got this together. We said, this is the pathway we're going to follow. Like many other interventions, especially nursing interventions, is to contact the patient, see how they're doing. But at every single office visit, the nurse or MA, when they room the patient, will record the score. It goes to the physician or the advanced practice provider. The APP then prescribes the preferred medication, and that they have a chance to see the patient, do a formal assessment, et cetera. Then there's a follow-up call by that provider's RN, and we'll go through what we used. We basically stole the brief pain inventory and chopped it up and made it convenient for us. But we'll talk about that. So then step 4, here's where it comes back. And here's where things would fall short. The physician or the provider doesn't know how the patient did. In my wife's practice, she'll prescribe a medication and then not see a patient back for a month. She has to schedule that patient to come back, and it's the same way. So we needed a way to close the loop. So the physician or APP makes adjustments, whether that's upward or downward titration, and or request them to come back. Okay, we need to see you. The pain is not relieved. Come back in. Let's keep talking about this. Because I'm sure everyone in this room knows there's only 2 types of pain in this world. There's malignant pain, everything else.
Did you delineate that from the get-go? Did you say, is your pain related to cancer, or is your pain related to, back pain?
Yeah, I mean, that was hopefully within where the physician or the APP saw the patient and did an assessment. We got a little overzealous at first, taking on some chronic pain patients, but we've shied away from that extensively. We have developed partnerships with a local anesthesiologist and it's called PCA Pain Center. What a clever name. But
ask the question. I guess I just need to get this clarified.
Oh, please.
In mind, is that, for COPE, when you're abstracting, you're looking at, did the patient report pain? And if you're using Edmonton or whatever,
Right.
the patient circled 6.
Yeah.
So there's nothing to say what that pain was.
That's right.
I'm not going to do anything about their rheumatoid arthritis. So, but for COPE, it's a 6, and that's a moderate, and you should have had a plan.
Right.
So,
Your plan could be the patient is managed through rheumatoid arthritis by the rheumatologist. And for OCM, if they rate a score of 1, you have to say something about it. I think that's
Sure.
that kind of gets to the point of people
Yeah.
that I think was raised earlier is it a meaningful measure? This is really an indirect measure, right? Because what
Right.
you want is for patients not to be pain, but that's not what we're measuring. We're just measuring
Yeah.
And see, the providers, they're very, they're like, I'm not saying anything about that because it has nothing to do with me. So I know it's nothing we can fix, but I just was wondering if there was a way that
Isn't-
say, do you have cancer-related pain?
Well, maybe
How do they know?
They might not even know where their pain's from.
I mean,
And then you got, associated, apart from pain, this general discomfort,
Right.
depression, anxiety, and all that stuff. And I don't feel well.
Right. Yeah, and that's where standardized assessment tools like Edmonton, I know that's played out, BPI, things like that. And I have some more slides, of course, that I included at the end that talk about documentation. Basically, the OPQRST U method. There's a U added now. How does it affect the patient's function? So that's a really good question. I'm not sure there's a great answer. So I think the struggle is real, as they say. Follow-up phone call. It is made again. I mean, we keep doing this. When we started this process, we used Tylenol for I'm sure a lot of people do, pre-meds for chemo. So we had to delineate which was a pre-med, which wasn't. It took a long time. And unfortunately in Mosaic and our EMR, we could not say Lyrica. choose Lyrica. I had to go 50, 75, every single milligram dosage of every single pain relief. So I'm talking Aspercream, anything. Anyways. So this is the questions the nurses ask, right? Has your RX been filled yet? Did you even get the damn med? Because a lot of them don't. What's the percentage of unfilled medications that are prescribed? I mean, it's huge. What's your current pain intensity? Okay, 0 out of 10. Everyone hates this question. Is it really bad? What is your acceptable level of pain? Well, my pain's a 6, but I'm all right at a 7. So this is better than it's ever been. Oh, okay. And the comments, essentially that's associated symptoms. My gut hurts, and then I get nauseous, but the pain brings on the nausea. Pain management options, non-pharmacologic, things like that, yoga, massage, etc. How am I doing on time? Do you know? Okay. This was an argument. This took a lot of convincing. This is a nursing resource education guideline that is pulled from the AHPM, some ASCO data, and CCN, which also contributes to that, ACS, American Society of Pain Management Nursing, American Pain Society. It distilled a lot of different recommendations on a very simple sheet. There's some back there too, so grab one on your way out. The rest are just general references that I found very helpful in the past. I brought some of those. But anyways, it goes through the guidelines, titration, what types of pain, okay? So that answers that question. Because no insult to an oncologist, but there's not always good pain management taught for that specialty, unfortunately. I think oncologists get good at it because it's out of necessity.
I thought I was good, but I think I stink. Really, I think as far as asking about functionality and about social support and making sure that the patient understands how to take their medicines and make sure the family understands that, look, it's okay if he takes his medicines. He's not going to get addicted.
Right.
Not to withhold drugs from him.
Yep.
I thought I was good, but I don't think I am.
Well, the fact that you don't think you're good actually means you're good. But I think everyone needs improvement, and that's part of this process. We developed every 3 months, hopefully, to revisit this, go over it, and discuss what is it. And I hope to do, through End of Life Nursing Education Consortium, there are a ton of case studies. Really, really good stuff. Anyways, we'll go on. So this is what this is based on. Everyone's seen the World Health Organization pain ladder. It was originally designed for third world countries, but everyone uses it. Biggest mistake, obviously, that we talked about was if your pain is a 6, you don't always have to start here, right? You can go to an opiate. Obviously, considering their previous exposure and if they're naive, et cetera. But also, another huge pitfall of this is people think, well, I go up here. These drop off. The adjuvants go bye-bye. I don't know why that happens. A patient's being treated for neuropathic pain, and someone DCs the Neurontin or the Lyrica. Anyways, we won't go there. These are, I think, and maybe I'm cheap, some really good references, resources, I would say, that most of these are free, like I said. I think this one isn't, the Opioid Prescribing Guide. The American Pain Society, this pocket guide, you'll see back there is the most well-loved book I ever had during school. It was amazing. So anyways, there's resources included here. If you need copies of this presentation, you can email me. I have business cards back there. Future conferences coming up to discuss pain and specifically palliative care. And then this is all the references, and I included some extras that I found very helpful. But that's it.
Tim, what did you do with us? I mean, is this for education for nursing? Or?
It is education for MA, nursing, social work, and physicians.
Okay. So what did you do with it?
We talked about it. I gave a presentation like this. At Lunch and Learns. That's the only time our staff is all together, unfortunately. And then even then, you know, you're looking at, well, we've got half the treatment room for this half hour, half the treatment room for this half. So, but that's what we did. A lot of education, you know, because pain is the fifth vital sign has now translated to opioid phobia and opioid epidemic.
So what are
So-
you seeing a lot of that in clinical practice then? I mean,
As far as what?
As far as now nobody wants to address it. Now they're afraid to write the
Oh yeah,
opioids
opioid
Yeah.
phobia is huge.
Yeah.
It is huge. I went to, my wife's a physician. We went to a pain management for the non-pain management provider or something like that. It was a Mayo Clinic seminar. And I'm not saying I'm an expert, but the stuff they were saying was opioid phobic. Get all your patients off opioids, adjuncts only.
There is that push. I mean,
There
our
is.
patients-
I mean,
There's legislation on it too.
Chronic back pain, person's been on Norco for ages, and well, now my primary care doctor won't prescribe it anymore, so they want me to do it. And it's,
Well,
it's, you know,
yeah,
Yeah.
my mom, I'm just going to tell you a personal example. My mother has rheumatoid arthritis. She lives in Florida, also cancer survivor. But, I mean, her pain med, she's seen a pain physician for probably 10 years. And, you know, they've done every intervention, and she's had back surgery, blah, blah, blah. But they had her on 7.5 milligrams of Percocet, up to 3 a day. And she's one of these people that writes it down every time she takes it.
Oh, dream
breaks it
patient.
in half because she's so afraid she's going to get addicted. Seeing the same pain providers for 10 years. And the last time she went in there, they had a new nurse practitioner who said, I think maybe we should see about getting you off from this pain medication. I was just livid that they would even say. So my mom calls me up, and my mom just said, well, you know, my daughter's a nurse practitioner. Maybe I need to talk to her about that.
Why don't you go talk to
So
her?
she called me and
Oh.
said, why would she be saying this to me? You know, I don't abuse it. I don't take too much. I never go through the whole month. She's always in pain, you know. And I'm like, Mom, and she's like, I mean, so now even the pain doctors
Yeah.
wanted to get them off the medicine.
Yeah, I was actually in an R01 trial. I stumbled into it. My mentor was running a trial on cancer pain and the African American experience in Detroit. And so we go to patients' homes and interview them and see how they're doing and check in, and then contact their oncology team at Carmanos or wherever they were. We had to argue for some of those argue. That's not the right. I don't know the diplomatic term. We're pulling our damn hair out. Advocate. Oh, there you go. I should know that as a nurse, but so yeah. I mean, the pendulum unfortunately has swung the other way.
I mean, I'll tell you, up here, well, we're from northern Michigan, there isn't a day that doesn't go by that there isn't something on the news about opioid abuse and how bad it is for patients and, you know, the whole Narcan thing.
Yep.
But it's just extrapolated to, I see it now in practice that some of the oncologists are like, you know, you better take some Tylenol. They don't want to write it.
really.
Yes.
Yeah.
So I figure if I'm not writing it, then who the hell should be? Because I remember
I know.
not so many years ago, Dr. Jack was, you know,
Yeah.
people, and
Given
every
it-
meeting you went to, I
Oh,
for
yeah.
internal medicine, not just the oncology, every internal meeting had to have something about pain
Every
and treating
time.
pain because they did not want this bad publicity. They didn't want somebody dropping off a patient at Beaumont, you know,
Yeah.
from Dr. Jack.
Well, and now, I mean, up north, it's going the other way. So I don't know what it is in the city. I'm sure it's huge. But
Yeah, there's a lot of code blues outside outpatient pavilion and patient has been
Yeah.
dropped off blue.
But
so.
it's what I find that I'm afraid that we're swinging to the other end of the pendulum and that our patients are going to suffer now because of that. I really, truly believe that.
Yeah. Well, like many things, insurance companies, et cetera,
Yeah.
we don't pay the price, the patient does. Patient suffers.
And that's the next step right there, is that because, you know, they made, hydrocodone a Schedule II, so, you know, it's limits who can write it. I I think insurance companies, because there's been such bad rap about some of those medicines, are gonna take it off the formulary.
Yeah,
I've heard
well,
news of it.
You said you're an NP?
Yeah.
Yeah, so you get the letters just like us that say you've prescribed
Oh, yeah.
this for this patient. We've noticed an uptick in, it's like, yeah, they have cancer. Stop bugging me. Like, I don't have time to read this crap.
But they're
Yeah.
looking at it, so
Mhm.
it's just scary to me. And I've seen just in our little, our practice that they're like, oh, they need to try some Tylenol, or why don't they try some Aspercream, or,
Yeah.
you know.
So do the rest of you guys have good experience with your EMR documentation? And is it easy to find the pain score? Is it easy to, oh, that's nice.
Yeah, it is. I mean,
And you have a standardized protocol? Go
So
ahead.
we had it as part of our review systems, the patient would work with circle it. But, so we were very good at documentation of the pain score, but we weren't very good at documenting the plan.
Yeah.
Even though you would see something was prescribed,
Sure.
but it had written in the note.
Yeah.
So what we did, we had ARIA for our EMR, and the way ARIA is set up is you have to review, this is part of my 66 clicks, you have to review the family history, the social history.
Right.
So we actually created an agenda item that you have to review, it forces the physician to review it. If the pain score is 1 or greater, because we're OCM, so you have to do it. So you have to
Because you need
review
to,
it.
it's back to, it's down in the face.
Right, and then the MA actually puts the meds in there, so the MA will say, just the patient reports taking. So the MA will write, patient reports taking fentanyl and Percocet for breakthrough, or the patient reports only taking Tylenol, and then I, as the provider, can
Fine,
edit that if I know, oh, well, they're also on a fentanyl patch, I can add that, or it just reminds me to put it in my note. So that was really helpful, and it wasn't, again, every time we asked the docs for another click, it wasn't that much work on the doctors, but it improved our
That's really
compliance.
good. We have already. So
Yeah.
that's a really
So
good.
that's what we did.
I need to find out how to do that.
Anyone
Email
else?
us,
I've
I
been
can
told
send you
we're
a screenshot of what we did.
5 minutes.
Yeah.
Time flew.
Well, I'm going through, one of my brothers has cancer, so I've been going through his journey with him, and it's interesting about the pain thing, because I'm doing coping for the first time, quantifying the pain, and I actually find that he has probably
Andy, yeah.
3 oncologists, neurosurgery, neurology, and kidney, and the way they talk about the pain, they bring it up, every visit, do you have any pain, Mr. Rowe? Yes, I do, what is it, 6? Okay, but they don't ever go further with that. They'll just say, do you need a prescription for your Norco rehab? They've never asked him, is the pain worse at night? Is it worse in the morning? Is there other methods we can do with it? I mean, it's never a discussion. I'm the one that has to say, well, Chuck, it's 6 right now. What was it when you got up? Is there other methods we can use? Like, I've actually asked if there's even something we can trade off with the Norco, some Motrin or whatever, but I'm the one, because I'm a nurse and I'm this advocate, constantly, trying to get him to really discuss his pain and
Yep.
help him with his pain. Like,
Sure.
I've done measures, ice, they've never said, because he had a
Yeah.
on me. Ice, heat,
Yep.
a neck brace for, no one has done anything but ask him what, if he has
sorry.
pain and what it is. It's really disappointing, and I work at Carbona's Cancer Center.
There's a pain clinic there. Oh, what's the NP's name? She's phenomenal. I used to consult her all the time
yeah,
on that study. She's brilliant.
Canadian,
Yeah.
yeah, really
Anyways.
good, but no one's even referred him there.
So I included some extra slides, and one of them was this OPQRSTU. And then there's notes about exactly what this is and how to document. So assessment's great, but the part of the documentation is also the plan. Gotta have a plan. So,
I like that you.
yeah.
How does that affect the patient?
How does it affect you?
There's old cart ice. This is the one we learned in grad school. I think most medical schools teach that acronym. But thank you, guys.
Thank you.